I will start the recording for this session. So we will start. Others, inshallah, will join. And we will share the recording on YouTube as usual, so everyone can have access to it. Okay, so Assalamu alaikum. Good morning, everyone. It has been a while, I know, but unfortunately quite busy, hence the delay. And this presentation took me almost 3 months to really fully prepare, too much details. And I had to be very careful with it because there's a lot of very important information. So if you have any questions, which you probably will, please keep it until the end of the presentation. Okay. So we can discuss them one by one. Any questions are welcome. For a quick glance over the agenda of today's presentation. So we will speak about thrombophilia testing in general. That's antithrombin, protein C, protein S, APCR, and some stuff related to it. And the other section of thrombophilia, which is lupus. Now, this presentation is not really technical. We will discuss some technicalities, but these are just to, build a base for the rest of the discussion. But this is not about how do you test for everything and the details. We are not concerned with the details in this presentation. Finally, we'll go over some details related to factor assays. Okay. But some of the lupus and the factor assays will be in the second part of this presentation next week. We will not cover them this week. Otherwise, it will be a very, very long presentation. So for a beginning, thrombophilia. Now, as you know, thrombophilia is a matter of someone being more susceptible or more likely to have thrombosis. So you're more likely to have clots. And that, of course, is not a normal situation. So we have to diagnose these patients to give them the proper treatment, which in most cases will be anticoagulation. What is the form of anticoagulation? That's not the matter of this presentation. But in most cases, the patient will be given anticoagulation either temporarily, months or years, or sometimes for life. So it's very important to diagnose it properly because anticoagulation can differ based on the case. It's not always the same. So proper diagnosis of thrombophilia cases is very important. And the tests that we use and that we advise the user are very critical. That's why I made this presentation, because I see that some users, they ask, oh, what test should I use? And then you say test X. They use test X even though they don't know sometimes that it's not the most appropriate for the case they are dealing with. So it's very critical for us to know these details to advise the user properly, because sometimes they'll just take our words and they run away with them. Anyways, now, I will not, by the way, you will see a lot of slides. There's a lot of text. I made sure to do that. So if you want to go back to the presentation, you'll find some relevant information without having to go back all the way through the video. So there is stuff that I will just skip. You can read it for yourself. Now, when we talk about thrombophilia and we talk about antithrombin, protein C, protein S, these are natural inhibitors in the body. So antithrombin is a natural protein, protein C is a natural protein, protein S is a natural protein. They are part of the normal anticoagulation in the body. Okay, of course, as we have coagulation, we have to control coagulation, and the ones who control it are protein C, protein S, and antithrombin. Lupus anticoagulant is not a normal physiological part of the normal anticoagulation system in the body. And APCR is a pathological condition. So when we say APCR, activated protein C resistance, this is not a natural physiological function. Okay, we will come to the breakdown of that because a lot of people, they confuse thrombophilia, antithrombin, protein C, protein S for being something that's abnormal. That's not the case, of course. Antithrombin, protein C, protein S are natural physiological proteins, and they're important. And their reduction or bad function can cause you problems. However, the presence of lupus or the presence of APCR pathologies is not normal, okay? So, getting into the important details. When do we test for thrombophilia? When do you say that this patient has to be tested for thrombophilia? Because as you know, thrombophilia testing is not a routine kind of test. You don't test every patient for thrombophilia. So how do we decide what kind of patient we test for thrombophilia? Now, this is not easy. It can be clinical. It depends on the history of the patient. It depends on the family history of the patient. It depends on the certain clinical suspicions. So not everyone and anyone who has an issue with thrombosis will be tested for thrombophilia. It really is quite dependent on many things. So as you can see, for example, this table, it shows you indications means who are the people who we may want to test for thrombophilia. Not indicated means these kinds of people, we don't really need to test them for thrombophilia, or sometimes uncertain interest, maybe or not. We need to test for thrombophilia. Sometimes it's the decision of the clinician, sometimes it's the decision of the lab, but mostly it's the decision of the clinician. So not everyone really needs to be tested for thrombophilia. And the people who are affected usually by conditions that will trigger testing for thrombophilia are not very common. It's relatively rare. That's why thrombophilia testing is not that common, generally speaking. So do we need to memorize these tables? Absolutely not. But it's just to give you an idea about when is the testing for thrombophilia decided on. Now, when we say thrombophilia testing, we are talking about antithrombin testing, protein C testing, protein S testing, activated protein C resistance, or sometimes people refer to it as factor V Leiden. It's partially accurate, not 100% accurate. Factor V Leiden falls under APCR. Lupus anticoagulant falls also under thrombophilia testing. There are other tests, but these are either rare or very specialized, and we usually do not cover them. So we will just talk about these 5 tests. Now, we put them or we bundle them under thrombophilia because issues with any of these 5 can trigger thrombophilia. That's why we call it the thrombophilia panel. Lupus usually is not part of the thrombophilia regular panel, or people don't usually bundle it to the thrombophilia panel, because it has a bit of a different testing pathway. It's a headache of its own, okay? But lupus anticoagulant falls pretty much under thrombophilia because the presence of lupus anticoagulant in the patient blood can cause a thrombosis, okay? Now, protein S stands out in a thrombophilia testing because protein S is difficult to work with. It's difficult to diagnose. It's difficult really to select the test. The test itself is not the most stable. It's expensive. So protein S physiology also is a bit complicated. So you need more testing to really know what's going on with the patient. So you will see protein S, you have a bit more details to speak about. But in general, a couple of noteworthy points about protein S specifically that are specific to protein S. Protein S in the blood comes in 2 forms. One is called free form and one is called bound form. Free protein S means it's floating in your blood on its own, free, not connected to anything. The bound form of a protein S, as the name implies, protein S is floating in the blood, but it's connected to another protein called C4b BP. BP means binding protein. So C4b, binding protein, carries part of the protein S in the blood with it. Okay? So we call this the bound form. The bound form of a protein S does not have any function, okay? At least in terms of coagulation. The free form of a protein S is the one that has the function of anticoagulation that we are concerned with in our topic, okay? So only the free protein S is active. This point is crucial because when we speak later on about the activity tests, we are only quantifying the free protein S because bound protein S has no function. It's not functional when it's bound. Okay, so as you can see in the last paragraph, activity assays for protein S can only detect free protein S. Activity assays such as clotting assays or chromogenic assays, the assays that require the activity of the protein for us to measure it, they require free protein S because bound protein S cannot generate any function. All right, this point is critical because when the user will say to you, your clotting protein S assay or chromogenic protein S assay, does it measure the bound protein S or the free protein S? You must know the answer because the answer is important for the diagnosis of the patient. Okay. Now, we said there's a free protein S, there is bound protein S, which has no function or it's inactive. And there is total protein S. Total protein S means the total, the sum of a free protein S and the bound protein S together. Okay? So total protein S means all protein S, bound and free. Do I need to measure total protein S? Yes, but in very, very rare instances. That's why this test you might have seen in your markets, it's either never requested or very rarely requested, okay? And the only way to detect total protein S is using ELISA assays. That's the only way available as of the moment. We cannot use activity assays because, again, bound protein S does not have a function. Okay, so we cannot quantify total protein S if part of the total cannot be measured with an activity assay. We will come to the details. Now, before we get into the technicalities of the test, there is some very important information. What are the products that we offer? What are the products that Stago offer? So we have the activity, okay, activity assays that measure quantity and function at the same time. Okay, when I say quantity and function, I mean the activity of the protein. So if the protein has no activity, you cannot measure its function. So you cannot measure a quantity. Like factors. If you want to quantify factors in a patient's blood, if the factor is dysfunctional, you cannot measure it because there is no function. You are measuring the clotting time. Clotting time is a function. So if I cannot measure the clotting time because there is no function, then I cannot measure the quantity. Okay? So we have activity and quantitative assays. Basically, it's the same thing. And these fall under STACLOT, STA clot, which is a clotting test. Whenever you say STA clot, this is a clotting test. And STA chrome, whenever you say chrome means a chromogenic test, photometric test. Okay, chromogenic is one category of photometry. So these are clotting assays or chromogenic assays. You cannot measure the clotting time. You cannot measure the chromogenic activity or the photometry values for a test like that, chromogenic, without the activity of the protein being present. This means the bound protein S cannot be measured with the clotting assays or chromogenic assays. So whenever I say clotting assay, whenever I say chromogenic assay, this is only about free protein S in the case of free protein S, okay? We will come to that later on again. Now, if I want to measure the quantity only without the activity being concerned, then I have to use a LIATest assay or an acerochrome assay. These are immunoassays, antigenic assays, okay? Because we are just measuring the amount or the presence of the protein without us quantifying its function or without its function or activity being concerned, okay? So when I use LIATest or acerochrome is ELISA. Whenever you hear acerochrome, it's ELISA. Whenever you hear LIATest, LIA, L-I-A, means latex immunoassay. It's an immunoassay. Whenever you see one of these two, this is an antigenic assay, immunoassay. Activity is not concerned at all. All right? So whenever you hear one of these two, we cannot detect any issues with activity. Whenever we talk about these two, we can detect issues with activity, but at the same time, we can detect a quantity. So now, what are the exact names of the assays? When we say if we have a qualitative defect or a quantitative defect, we can detect them with these two, STACLOT and the STACROM. So in the case of protein S, we have STACLOT protein S. We have also STACLOT protein C. We have STACLOT activated protein C resistance, APCR. And all of the lupus line is STACLOT. Okay, it's a clotting test. STACROM, we only have STACROM protein C. We don't have STACROM protein S, and we have STACROM 83. Okay, which is your regular 83 assay. Now, for the quantitative only assays, the assays that cannot detect any issues with activity, that do not require activity to do the test, we have LIATest free protein S, and this one is pre-calibrated, by the way. We also have an assay called LIATest antithrombin 3. This is not an IVD kit. So if the user ever asks for this LIATest antithrombin 3, it's an antigenic antithrombin 3, you have to tell them this is not an IVD test. It's a research use only test. Okay. When do my user need it? We'll talk about that later on. Finally, acerochrome assays. We have acerochrome for protein C. We have acerochrome for free protein S only, and we have acerochrome for total protein S. So we have two different ELISA kits for protein S. One is free, and one is total. Okay. Now, before we go into the testing, the details of the testing, which is very important, there is a tiny point that will make your life a little easier in the few slides to come. Whenever I say a type 1 deficiency, I mean that the quantity of the thing that I'm measuring is low. I'm only talking about the quantity. So when I say type 1 protein C deficiency, means the protein C quantity is low. I'm not talking about the activity. The activity is absolutely normal. Everything is okay. Only the quantity is low. Whatever is the reason. Type 1 deficiency means the quantity of the thing I'm measuring is low. Type 2 deficiency means maybe the quantity is okay, but the function of the protein is defective. Maybe there's a mutation or. So I'm talking about the quality or the activity. They are all the same thing. Type 2 deficiency is a problem with the quality, with activity, with function. All these three mean the same thing. Now, there's a special case for protein S. We have something called type 3. Type 3 is really a special case. We will discuss it in very, very brief terms, okay? Because actually it's just a low amount, or it's a bit of a tricky case where actually the amount is low, but at the same time, it's a bit of a problem with the function. Okay, so type 3, it's a special category on its own. But type 1, deficiency in quantity. Type 2 is deficiency in quality or function. So starting with the protein S, which is, to be honest, the most tricky one. So generally speaking, whenever we are screening for any kind of parameter that may have a problem with the quantity or may have a problem with the quality, ideally, we would have a test that would detect issues with activity or if it present issues with the quantity. So if the patient has an issue with activity, I would run the test. The test would say, oh, you have a problem with activity. Or if the patient has an issue with the quantity, the test would say, yeah, maybe you have an issue with the quantity. So ideally, we would run a test that can detect activity issues and the quantity issues. These tests are the clotting tests and the chromogenic tests, not the antigenic tests, like LIA test or a serochrome. Antigenic tests cannot detect the quality. Okay, they can only detect the quantity. Now, in this case, you would think, okay, then ideally I would start running for the patients stack clot to protein S or stack clot to protein C or stack chrome protein C. However, that is not the case for protein S, which would be counterintuitive. We just said we want to detect activity and quantity issues. However, the current guidelines, they say we are not recommended to start testing for patients with activity protein S assays. Activity protein S assays, I'm talking about stack clot protein S. Okay? And ideally, the lab would start testing the patient who is suspected of protein S issues using an antigenic assay. That would be a serochrome or LIA test-free protein S. Now, what is the reason? If you want a more detailed breakdown, it's in the notes of the slide. But the point is, or the two most important points are, first of all, the patients who actually have type 2 defect or the qualitative issue or the function issue of protein S are very rare. This can be anywhere between 1 and 5% of the total population who have a protein S issues. Second of all, the stack clot to protein S or any activity protein S assay, they are very sensitive to many different issues. So actually, when you run the activity protein S assay as your routine screening assay for protein S issues, maybe you will catch some patients who have type 2, but you will misdiagnose many patients who are actually normal, they don't have protein S issues, because this assay is very sensitive to interferences. So for the general good, and let's say to reduce the damage to everyone else overall, we ideally say that it's recommended to start with an antigenic protein S assay because it's much less susceptible to interferences than the clotting or the chromogenic tests. And we only use the clotting protein S assay or stack clot protein S assay if the antigenic protein S assay was negative, but the clinician is really suspecting there's a protein S issue. In this case, we can run the clotting protein S assay as a second step, not as a first step. Okay, and if you go into the notes of the slide, you have these slides with you. You can see more references that talk about this point in more details, but this is pretty much the summary of what they say. Now, onto the more commercial side. If I want to explain all of this scientific stuff to the user, great, they will ask you a simple question. Okay, your assay is more expensive. Stago assay is more expensive. Why would I buy it, for example, instead of buying something from Werfen or Sysmex? By the way, small point. Most of the specialty assays in the market are run either by Stago analyzers, Sysmex analyzers, or Werfen. Roche is pretty much non-existent in the market, and usually the other smaller providers are not really selling specialty testing. Okay, so our main concerns when we are talking about specialty testing are Sysmex and Werfen. Okay, that's why I did not cover the other competitor. Now, what are the advantages of our Liatest Free Protein S kit, which should be the first line of testing in case of Protein S? First of all, it is the only kit in the market that's pre-calibrated, like fibrinogen, like D-dimer, like protein, like prothrombin PT. Okay, we are the only ones who have a pre-calibrated antigenic protein S assay in the market. Okay, which of course saves the cost for the customer and the effort. They don't have to buy calibrator, etc., etc. They don't have to deal with the failures of the calibration and so on and so forth. The second point, it has, as you can see, 5 days on board stability. For the 6 ml kit, we have 2 ml kit, we have 6 ml kit. The 6 ml kit has 5 days stability on board. I think the 2 ml one has 1 or 2 days. I'm not sure. You can find it in the IFU. Siemens kit has only 3 days of stability. So that's an advantage for the user, of course. Plus, we have 2 different sizes of the kit. So if the user has a very low workload, they can just buy the 2 ml. If they have a lot of workload, they can buy the 6 ml. Siemens or Sysmex, they offer only one size, which means that the user may have a lot of wastage in the kit that they paid for, and they did not get any tests out of it. Now, for Stacklotop Protein S, Stacklotop Protein S or Activity Protein S in general are problematic tests for all manufacturers. The problem is with the nature of the test, it's not a manufacturer thing. It's that a Protein S itself is a difficult test to work with. Now, our advantage over the competitors is that we have the least amount of interferences compared to other competitors, Werfen and Sysmex specifically. So we don't have any interferences from factor 5 Leiden patients or factor deficiencies, whereas Siemens, Sysmex, whenever we say Siemens, Sysmex is the same thing, okay? They have issues with factor deficiencies when the patient has a factor deficiency of any type, or a factor 5 Leiden. So this might cause protein S results to be wrong. Okay, we don't have these interferences. So we have an advantage over Siemens Sysmex. For Werfen, we're more or less the same, to be honest. Now, before I move to protein C, is everything clear about the protein S? I don't want to leave a protein S hanging. Does anyone have anything that they want me to repeat, or should I move on? Please let me know. It's very important.
It's clear.
It's clear. Anyone else?
It's clear, like.
Okay, perfect. I'll move on to protein C then. So for protein C testing is less complicated than a protein S, and it is generally simpler, and you have more options. By the way, one small point that I forgot to mention about protein S. Protein S type 3 just means that the bound protein S amount is normal, but the free protein S amount is low. So for us to diagnose the type 3 protein S deficiency, you need to run the free protein S, you may need to run the bounded protein S, but also you need to run the total protein S assay. And this will be costly and complicated for diagnosis. Not to mention that a lot of studies, they say that type 3 protein S deficiency is not clinically relevant. It means people who have type 3 deficiency of a protein S generally are not at high risk of thrombosis. Okay? And there's a bit of a debate. That's why you might notice that the bounded protein S assays, total protein S assays are very rare. Some countries they're not even ordered. And that has to do with that type 3 usually is not that common and is not that important. Okay? Going back to protein C. Now, for protein C, we have two types of assays. We have the clotting protein C and we have the chromogenic protein C. Now, I have a small question for you and I want you to write in the chat. What do you think? Are these both activity assays? Are they both functional and quantitative assays? Or they are only activity assays but not quantitative? What do you say? So are they both quantitative and activity, or are they activity only and quantitative? And do you think there's a difference between clotting and chromogenic? Should we use one from the other? I want to hear your opinion before I continue with the presentation. Okay, so both quantity and activity. Does anyone else have a different opinion? Okay, so far Mahmoud and Asif, they say both are the same. Does anyone disagree? I'll give you 5 more seconds to write a comment. Okay, so everyone agrees, it seems. Yes, clotting and the chromogenic, as I said earlier, both can detect issues with activity and issues with the quantity. So if the patient has a quantity issue, we will detect it. If they have a quality or function issue, we will detect it. Now, why do we have both? I'll explain in a second, but there are few differences that we need to pay attention to. Now, in terms of the commercial concerns, the user would say, okay, why should I take from you clotting protein C? Why should I take from you chromogenic protein C? Especially that the clotting protein C per test tends to be more expensive. Plus, the stability is less. It's significantly shorter stability time for clotting protein C. The one major advantage of clotting protein C over the chromogenic protein C is that clotting protein C assays in general, STAG or otherwise, they can detect almost all, but in our case, all the number 1 or type 1 and type 2 deficiencies. We don't have type 3 deficiency with the protein C, either type 1 or type 2. So our clotting protein C assay can detect all kinds of defects, type 1 or type 2. However, since it is a clotting assay, it's sensitive to many different sources of interference. Plus, it's very short stability and it's more expensive. However, the chromogenic protein C assay, it's cheaper because it can stay on board for longer. Okay, and the cost per test is cheaper, to be honest with you. Okay, now of course these prices vary from distributor to distributor, but I'm talking in general. Chromogenic protein C assays cannot detect all type 2 deficiencies. We'll discuss this in the slides to come. Okay, so some deficiencies will be missed if you only use chromogenic protein C. So what should I use? What should I do in this case? One of the suggestions would be use the chromogenic protein C as a first line testing. If the clinician still thinks that the patient is having an issue that might be related to protein C, you can run clotting protein C in this case as a second line of testing to confirm. Okay, if you find the chromogenic protein C is normal, but the clotting protein C is not normal, then at this case, we will be suspicious that the patient has a type 2 defect that the chromogenic PC is not detecting. We'll talk about that. Another advantage of chromogenic protein C, since it's a chromogenic assay, it's not affected by the things that affect the coagulation assays, such as factor VIII deficiencies, lupus, direct thrombin inhibitors, DTIs, direct thrombin inhibitor, okay, such as argatroban, the bigatran, all of these medications. And not to mention that the current recommendation is to start your testing with the chromogenic protein C. Okay, as I mentioned to you, the recommendation, you start with the chromogenic. Clotting protein C is the second line of testing if we are still suspicious that the patient may have an issue with the protein C that our assay is missing for the reason I mentioned to you. Okay. By the way, what are these type 2 assays that we are missing? It's generally some mutations, okay, which are very rare. Some people have these mutations. That's why it's a type 2. Type 2 usually causes dysfunctional proteins, but not always. So some people who have these mutations, they might not be detected by chromogenic protein C. Okay, but what are they? It's beyond the scope of this presentation, but you can easily find them in some literature. If you want, I can share those with you. Now, a bit of a quick summary. What is our commercial advantage against competition? First of all, for the chromogenic or the stachrome protein C, our advantage is that we have 21 days on board stability as compared to 15 days for Siemens Sysmex. Okay, that can be useful for especially referral labs who get a lot of requests all the time, or for very, very big hospitals. And anyways, thrombophilia testing is not done in small labs, so this is usually relevant for the user, the high stability. The second very important point is that stachrome protein C is really not affected by most interferences that you'd encounter in samples. However, for Siemens Sysmex, they don't have any clear instructions or details about the sources of interference in their kit insert, which can be quite concerning for the user because I don't know what can interfere with my assay. So how do I trust my result? Okay, so that's a very big issue that Sysmex has with their protein C assay that's from Siemens. Because really you don't know what are the interferences. It's not listed anywhere. I even checked the IFUs myself multiple times. I checked different resources. They don't list that, which is quite strange. Anyways, the advantage with the stack-loaded protein C is the same thing with the protein S. We don't have issues with lupus and factor V Leiden for the stack-loaded protein C. Okay. For Werfen, pretty much we are equivalent to Werfen in terms of stack-loaded protein C and their protein C clotting assay. Now, antithrombin is on the more interesting side. For antithrombin, we only have a chromogenic assay. We do not have a clotting assay for antithrombin because antithrombin does not have a clotting activity. Okay, you cannot quantify antithrombin with its clotting activity because it has no clotting activity. The thing is, we have a chromogenic assay only, but we have an antigenic assay. If you remember, I said LIATest antithrombin 3, it's an antigenic assay. Anyways, the name tells you LIATest. But LIATest antithrombin 3 is not an IVD assay. So if the hospital decides to use it, they would have to validate it. They would have to establish their own claims, their own reference ranges, their own sensitivity, their own everything. All right, so this is a research use only kit. Now, antigen assays, as you can see, as you can read, cannot detect type 2 deficiencies. We spoke about that. They can only detect type 1 deficiencies, but stachrome also can detect type 1 deficiencies. So why would I need LIATest antithrombin 3? Now, there's a very good point behind this question, and as you can see, it's explained. Around 80% of the patients who actually present with symptoms, who have symptoms because of antithrombin deficiencies, are type 1. So the vast majority are type 1, which we can detect with both assays, stachrome and LIATest antithrombin 3. And we have stachrome, so we don't need LIATest antithrombin 3, especially it's a research use assay. Now, the rest of the patients who have symptoms, okay, 20% of the total population, which will be missed if we use the LIATest antithrombin 3. Do you want to run a test that will miss 20% of your patients who have an issue? Of course not. Not to mention, stachrome, the chromogenic assay, can detect both types, 1 and 2, so we can detect all kinds of issues, okay? If the patient is type 1 or type 2, the treatment is the same. The clinical issue is the same. So we really don't need LIATest antithrombin 3 except for very rare cases. For example, if we suspect that a certain family, they have a hereditary issue in the family where they have a problem with antithrombin 3. This is one of the few uses for LIATest antithrombin 3. That's why this test is almost never ordered. Even in our orders in our region, we almost never see anyone order this test because it has very, very, very limited uses, okay? And this is usually related to, again, establishing if this family really has an issue with most of its, let's say, members with antithrombin 3. So this is usually hereditary issues, which is not very common. By the way, sorry, this was stachrome antithrombin 3, not a protein C. Only now I realize this. So this is stachrome antithrombin 3, not PC. I will modify this right after this presentation. Now, the advantage that we have is that we have 7 days on board stability compared to only 2 days for Siemens Sysmex. That's fine. The more important point, if you see point 2, our Stachrome antithrombin 3 is sensitive to certain mutations that cause type 2 antithrombin deficiency. Okay, so this is a qualitative deficiency in antithrombin. Our kit is sensitive to mutations that Siemens Sysmex cannot detect. Okay, so as you can see, Siemens Sysmex cannot detect Stockholm, Denver, and Cambridge mutations. Stockholm, Denver, Cambridge, these are the names of the mutations. Okay, so if the patient has these mutations, the Siemens Sysmex system cannot detect these mutations. So the patient will go undiagnosed or misdiagnosed, whereas our kit can detect it. Okay, so for the user, the important part is that we can detect things that Siemens Sysmex cannot detect. Okay, plus we have a longer stability. So yes, maybe it's more expensive for Stago, but then it comes at a cost for the patient. Plus for the lab, you still have the stability thing that will also make it up for you in terms of price. Now, of course, that is not the solution for each and every customer. You cannot solve problems for each and every customer, but this really is a big advantage for you to use. Now, moving on from antithrombin. Before I go into APCR, everything is clear for everyone as of now?
Yes.
Any questions before I move on? Okay. Now, APCR. APCR is one of the tests which are generally more misunderstood. APCR, APC means activated protein C, R means resistance. Resistance by what? Now, small details. Protein C is a natural anticoagulant in the body. Protein C is a protein that deactivates factor 5 and factor 8. When you have any kind of a bleeding, your body wants to stop the bleeding, coagulation factors are activated, but we cannot have them activated everywhere and forever. At some point, we must stop them. Protein C is one of the proteins in the body that stop coagulation factors at a certain stage. So when protein C is activated, it's doing its job. And one of the things it should inhibit will be factor 5 and factor 8. So if factor 5 or factor 8, for example, resist deactivation by protein C, then protein C cannot do its job. Protein C cannot do its anticoagulation job, which means you're at risk of thrombosis, okay? Because one of your anticoagulants cannot do its job, which means you are more likely to coagulate. So activated protein C resistance means protein C is being resisted by one of the things it should inhibit. Okay, and generally this refers to factor 5, much more rarely by factor 8. Okay, so in most cases of activated protein C resistance, factor 5 is the problem. And this is known as factor 5 Leiden. Leiden is the name of a city in the Netherlands. And this is where the first case was diagnosed with this mutation. Factor 5 Leiden simply means that factor 5 has a mutation. And when factor 5 has this mutation, protein C at some stage will come to factor 5 to inhibit it, but factor 5 resists inhibition, which means coagulation continues. So you are at risk of thrombosis. Most cases of activated protein C resistance, again, are caused by factor 5 Leiden. However, some cases of activated protein C resistance are not caused by factor 5 Leiden. They are acquired APCR cases. So for example, if someone has too much of factor 8 for whatever reason, protein C goes to do its job, but it encounters so much factor 8, it cannot inhibit a lot of it. So coagulation continues. You are at risk of thrombosis. These are rare cases, but they exist. Generally, these are called acquired APCR, acquired activated protein C resistance. Okay. Now, all APCR assays in the market are clotting assays. We do not have antigenic assays for APCR because the nature of the test is that we have to run a clotting test and we have to see how well can a protein C stop it. Okay, so there is no antigenic assay for this because what we are testing is the functionality of a protein C and is it being resisted. You cannot test the functionality of something with an antigenic assay. That's why all the assays in the market for APCR are clotting assays. Okay, so just to emphasize, APCR assays are all clotting based. Okay, it's called StackClot APCR in our case. If APCR is positive and factor 5 is factor 5 Leiden suspected, we have confirmed by genetic testing. And remember, factor 5 Leiden in most cases causes APCR, but not all cases. Okay, this is a very important point. Now, this is what I just explained, that you need to check the activity, and you cannot check the activity with an antigenic assay. Okay, there are some notes under this slide. If you want to read them later on, you can refer to that if you want to read and understand a little more about this topic. But this is basically the summary. Now, what are our advantages in the market? To be quite frank with you, we don't have an advantage in the market that will be absolutely dominant, let's say. You cannot just go and convince each and every single customer that our assay is better. Yes, you have very good results. There are advantages, okay? But I cannot say, for example, it is the kit that will dominate all kits. No. There are certain points that some users may not like, but most of the users, they like this kit and they like its performance, and its performance is excellent, okay? Now, the advantage that we have is that you don't require any calibration for this kit. If my memory serves me well, Siemens Sysmex kit requires calibration, if I remember correctly. So some competitors in the market, they require calibration for this assay. We do not need that. Plus, we have a predefined cutoff. Means if you open the kit insert, Stago has defined for you a clear cutoff. If your clotting time with the APCR kit is more than 120 seconds, okay, you are normal. Less than 120 seconds, you are abnormal. Simple as that, okay? Because the competitors, they can use ratio. With the ratio, you have to run 2 tests. You divide one by the other, and it's a bit of a hassle, okay? For us, it's much easier to use this kit as compared to competitors, all right? And with this, we are done with the thrombophilia, antithrombin, protein C, protein S, and APCR. Any questions before we move on to lupus? Does anyone have any comment or a question, or should I move to lupus?
It's all right. We can move forward. Thank you.
All right. Now, this is not your typical presentation about lupus. Of course, I have to make some points which are repetitive, but these are important to build the narrative. But I'm not here to tell you how to do the testing. I'm not here to tell you about ratio this, cut off that, okay? That's a different story. This is more on the marketing side of things. And for you to understand how this works, so you can pitch them to the customer. Now, what exactly is lupus? Now, of course, I know you all have an idea more or less about lupus, but just a quick revision for some important points. Now, this blue thing is a coagulation factor. The way some coagulation factors, namely factors 1, 9, 7, 10, 9, 7, and 2, okay? Again, factors 10, 9, 7, and 2, as you can see them. These factors, they cannot sit on the surface of phospholipids, which are required for coagulation. These factors cannot sit on the surface of phospholipids to do their function, okay, without calcium. So these factors will connect to calcium. Calcium will connect to phospholipids. And if they are not sitting on the surface of phospholipids, these factors cannot do their function. Again, factors 10, 9, 7, 2, if they are not sitting on the surface of phospholipids, negatively charged phospholipids, they cannot do their function. So no clotting. Understood? This is the whole premise of what lupus anticoagulant is. So, for example, I have a normal patient plasma. FA means activated factor. So I have factors. They're sitting on the surface of phospholipids, this yellow stuff. Okay. You get a normal APTT result. You get a normal PT result. Everything is fine. Okay. Full normal plasma, the same. We don't have any issues. So if you don't have lupus, The factors can sit on the surface of phospholipids. They do their job, so you'll get normal APTT. Now, if the patient has lupus, as you can see here, lupus patient, this yellow thing represents lupus. Lupus antibodies, they take up space on the surface of phospholipids. They take the place of coagulation factors. Means coagulation factors cannot sit on the surface of phospholipids, means they cannot do their function, means you don't get clotting. Clotting is a prolonged. So lupus antibodies simply take the place of coagulation factors, means coagulation factors cannot do their function, means that you get clotting that is prolonged. This is very critical for you to understand the testing of lupus and what you can offer to the customer. Okay, this slide might look like, oh, it's just technical stuff. No, it's really crucial for you to understand the rest of this presentation. So, just to re-emphasize, lupus antibodies, they take a space on the surface of phospholipids, which are present in your reagents, and the same in your blood. Lupus anticoagulants, they take up the space on the phospholipids that coagulation factors must use, which means coagulation factors cannot do their job. Coagulation factors cannot do their job. Clotting is prolonged. Okay. Now remember one important thing. Prolongation of the lupus anticoagulant that happens in the testing does not mean the patient will bleed. It's a bit of a complicated thing, okay? But we'll not go there. Lupus anticoagulant is a thrombosis risk for the patient. Remember, it's under thrombophilia, okay? Why? We will not go through that bit of details. Now, lupus antibodies, just a small point because that has to do with the commercial aspect. Lupus antibodies are one of the 3 types of antibodies that we call antiphospholipid antibodies. Remember, lupus anticoagulants or antiphospholipid antibodies in general, they take up the space on the surface of phospholipids where coagulation factors should sit. So this means coagulation factors cannot do their function, okay? So antiphospholipid antibodies are a heterogeneous, means they're a different or a group made up of different things. It's a family of antibodies made up of different kinds of antibodies, okay? They're not one thing. So what are these different kinds of antibodies? We have lupus anticoagulant, our friend in here. Another family is called anticardiolipin antibodies. And the last one is called alpha anti-beta 2 glycoprotein 1. Anticardiolipin and anti-beta 2 glycoprotein 1 are tested for with ELISA or chemiluminescence. We cannot do testing for them with clotting assays. Lupus is only tested for with the clotting assays. Okay, so again, lupus, we test it only with phospholipid-dependent clotting tests, as you can see. For anticardiolipin and anti-beta 2 glycoprotein 1, we use either ELISA or chemiluminescence immunoassays only. We do not have clotting tests for anticardiolipin and anti-beta 2 glycoprotein 1. Why did I say phospholipid dependent? Because remember, the whole issue with lupus is that it takes up phospholipids away from coagulation factors. So that's the way we design our tests to test for lupus. Now, just a small point to make. In this presentation, or generally when it comes to Stago training materials or most training materials out there, people usually rely on ISTH guidelines, okay? The International Society of Thrombosis and Hemostasis. It's a regulatory body like CLSI. BCSH is also another one. There are many different regulatory bodies, but ISTH is the most commonly followed. They have a guideline that was released in 2020, and this is the one that we usually rely on, even in our advice to customers. Okay, so whatever you will see from this slide onwards is reliant on ISTH 2020. Anyways, the differences between these three, the ISTH, CLSI, BCSH, are very small, and we will not touch on them, okay? This is not the presentation point. Now, you definitely have heard that lupus testing, we have screening tests and we have confirmatory tests, which is generally a very big point of confusion, especially for people who don't cover the technical part. So sales or service people usually are confused by this part and they cannot blame them. It's quite confusing and it can be sometimes counterintuitive. Now, For lupus testing, we always work in 3 steps, and this is the recommendation of ISTH, CLSI, BCSH. 3 steps. Step 1 is a screening test. Step 2 is a mixing assay, very similar to PT mix or PTT mix, same concept. And the third and last step is the confirmation test. Now, it's very crucial that you understand the following. Screening test can tell you if you may or may not have lupus, but it can never confirm that you have lupus. This is a huge mistake that some users make. We will cover it later on. Again, screening tests can tell you if you may or may not have lupus, but they can never confirm it. Mixing test can tell you that the prolongation you see in the screening test is caused by a factor deficiency or by an inhibitor like heparin, like DOAX, like lupus, like antifactor antibodies. Finally, confirmation test from the name. Confirmation test is the only way for you to say that the sample has lupus or does not. You can never tell that a lupus sample or a patient sample, sorry, has lupus or not unless you run the confirmation step. You don't run confirmation test, there's no way for you to know if it's lupus or not. Okay? For example, you are working in the kitchen, and after a very busy couple of hours in the kitchen, your shirt is wet. Maybe it's the soup, maybe it's the water, maybe it's the oil, maybe it's you never know what. So now by looking at your shirt, you know that there's a liquid in your shirt. If you look at your shirt and it's dry, there is no liquid. Okay, so this is a screening test. You looking at your shirt is a screening test because just by looking, you know, my shirt is dry, there is definitely no liquid on it. But if your shirt is wet, there's a liquid on it. But what's the liquid? I don't know. The screening tests in our case here can be prolonged by lupus, can be prolonged by heparin, can be prolonged by direct oral anticoagulants, can be prolonged by antifactor antibodies. You don't know. Okay? They just tell you maybe you have lupus, but if they are negative, you don't have lupus for sure. Okay? Now, if the screening test is prolonged, okay, we do a mixing test. Mixing test will just allow you to know one thing. Is the cause of prolongation of the screening test factor deficiency or an inhibitor? The inhibitor can be many things. Now, when we go to the confirmation test is like trying to check on your shirt. There's a spill on your shirt. If it's oil, okay, you let it dry. The oil will not go away. I know that's too much laundry examples, but that's the only thing that came to mind. So if you try to wash the oil and it doesn't go away with water, you know this is oil because it doesn't go away, it doesn't dry up. If you wash it with soap, it goes away. It's probably oil. So that's how you confirm. You need to run a test to confirm. If you do not confirm, you would never know. So that's one very crucial point with lupus. No confirmation test, no lupus diagnosis. Okay? We will come to this point later on because it's very, very relevant to the testing offered to the customer. Now, for a screening test, one point I forgot to mention here. For screening tests, we have 2 types of tests. We have the DRVV, you know, STAC-LOT DRVV screen, STAC-LOT DRVV confirm. And we have for APTT-based assays, we have APTT-based screen, we have APTT-based confirm. Now, DRVV-based screen test is the STAC-LOT DRVV-S. You have 2 and 5 ml volumes. The APTT-based screening test is the PTTLA. That's why we always tell customers, PTTLA, do not use it to diagnose lupus because it's a screening test. You cannot say that the patient is positive from a screening test. You need the confirmatory one. Mixing test. I do it by running my patient sample, mixing it with pool norm. That's one of the reagents we have, you know, pool norm. And then we run the screening test again. So we mix our sample with pool norm, then we run the screening test again. Okay? Finally, the confirmation test. For DRVV-based confirm, the reagent is called STAC-LOT DRVV confirm, only a 2 ml version. The APTT-based confirm test is STAC-LOT LA, okay? Which is, I know a lot of users do not use it because they think PTTLA is enough. That's completely incorrect, okay? So this is very important for you to know. Now, as you know, you have the APTT test principle. I just added this for your information. And we have the DRVV test principle. APTT test, you know, we activate the intrinsic pathway, then the common pathway. DRVV test is different from APTT in one simple way. DRVV test does not start from the intrinsic pathway. We immediately activate the common pathway. Okay, DRVV means dilute Russell Viper venom. This Russell Viper venom activates factor 10 directly without the intrinsic pathway. Okay. Why do we have two tests? Why do we need two tests? It's more expensive for the user. There's a very, very good reason. We will cover it shortly. Okay. And this is, again, very important from a commercial aspect or from, I would say, marketing aspect. Now, I want your answer to this slide. Now, I assume I sent you these slides in the email, so some of you may know the answer, but if you did not read the slides, what do you think is the worst and most common mistake that customers do with lupus testing? What are your guesses? Or what have you observed? I want to hear from you. If you can type in the chat your answer. I'll give you 30 seconds to answer that. Okay, interesting answers so far. I'll wait for Mahmoud's answer, then I will show you the answer. Okay, yes. So 3 of you answered correctly, is that the customer relies solely on the screening test, which is a horrible mistake. Because if you say, oh, the screening result is prolonged, this means the patient has lupus, it can be heparin, it can be factor deficiency, it can be anti-factor antibody, it can be lupus, maybe, yes, but it can be many other things. So maybe the patient has a factor deficiency and you say, oh, the patient has lupus. Let's give him anticoagulation, but the patient has a factor deficiency. You give him an anticoagulation, you make it worse. Now, of course, that's a very horrible mistake. Usually we would correlate with the clinical presentation of the patient. But this is the most common and the worst mistake that honestly I get complaints about. Users just rely, especially PTTLA. I don't know what's the fascination of PTTLA, but a lot of the time I get reports that customers using PTTLA to release the patient result as positive, which is a horrible mistake. Because PTTLA will be positive in so many cases. Okay, so a lot of the times, if you say the patient is positive for lupus based on PTTLA, I can tell you maybe 15%, 20% of the patients will be actually lupus positive. The rest will not be. That is from clinic to clinic. So it's a horrible mistake, really. Without running the confirmatory test, that is the RVV confirm or Staclot LA, you can never say that the patient is lupus positive. Now, to give you an idea about why do we run both APTT-based assays and DRVV-based assays at the same time, of course, it's more expensive. Of course, it's more work. But there's a very good reason. And actually, the reason comes and is supported by ISTH and CLSI and PCSH. So all the current guidelines, they advise the users to run both APTT-based assays and DRVV-based assays. The reason, if you look, by the way, this evaluation is specifically for our reagents, so it's a very, very good point for you to use. If you run PTTLA test only, because lupus anticoagulants are different antibodies. When you say lupus anticoagulant, it's not one type of antibody. It's different types of antibodies that are slightly different from one person to another. You will not be able to detect all patients who have lupus if you use only APTT-based screening test. The same applies for DRVV. You cannot detect all lupus patients only based on DRVV-based screening test. However, if you combine both of them, you are likely to catch 100% of all the patients that have lupus. but that's only for stagger agents according to this evaluation. If you look here, PTTLA in combination with DRVV screen assay for this study, okay, detects up to 100% of the lupus patients. I did not say diagnose, I said detect, okay? Means none of the lupus patients showed as negative in the screening assay. Be careful, I said detect, again, not diagnose. Detection, diagnose, and diagnosis, completely different things. Now, if you look, I think this was Siemens. This was our PTTA, your regular PTTA. It's not as sensitive as PTTLA, so of course you can expect it to miss some patients. Don't remember these brands, but anyways, this was Siemens, for example. See, for Siemens, you combined 3 assays and you still have missed almost 25% of the patients. So when you use PTTLA and DRVV screen from Stago, and there are many studies that support the same claim, you are likely to catch all the patients that have lupus. But for competitors, you might miss a decent amount of patients. That's why we tell the user run both PTTLA and the RVV screen. Why? It's more expensive, it's more work. Yes, but your screening, if you run just one of the two, your screening might be negative, but the patient actually has lupus. That's why we recommend them to run both. Okay? This is where we'll stop this presentation. We will continue from this slide next time, because now it has been 1 hour. Okay? And if you have any questions at this point, please let me know. Okay, for now, we will stop.
Thank you so much, Laif.
Like,
You are very
it
much
was
welcome.
an amazing session, and really it clarified a lot of things